Okay, I think we're going to get started because it is 3:30. We are so privileged and excited to be talking to you all this afternoon about how to design a geriatrics and emergency medicine curriculum. So my name is Nida like Nida sweater, Pegasus like Pegasus but with a D. I am the medical director of our age-friendly emergency department at the University of California, San Francisco, and I have these wonderful colleagues with me.
Hi, I'm Jim Hardy like the Hardy Boys, and I also work at UCSF, and I'm a colleague in this work.
And I'm Eric Isaacs. There's no like for my name. And I'm directing the AGEM media at San Francisco General Hospital at UCSF.
So today we have a few things that we're going to talk about. First and foremost, obviously, how to outline a needs assessment for a geriatrics curriculum, how to integrate that kind of content into the curriculum that exists at your institutions, different modalities of learning and how to apply those to curriculum, and then, of course, what does this have on us as faculty and the impact on us?
All right, so like why are we here? How did we get here?
Well, our fantastic voyage began in 2018 before the pandemic, when UCSF got a grant to create a geriatric emergency department, or GED. And then, in an effort to make San Francisco a geriatric city of excellence, we got further funding to make a GED in 3 sites in the city: our site, Eric's site, and High School.
Wait, Jim, you keep using this acronym GED, and then you say Geriatric Emergency Department. Where can I find that on a map?
You cannot find that on a map, really. So you might think that a GED is a separate place, a separate building.
And unless you worked at UC San Diego, that is not the case. It's far from true. In fact, in our emergency departments, it's not even a zone inside the emergency department. A GED is essentially an extensive bundle of screening tools, protocols, and care pathways. And if you're lucky and have a fancy GED, you also have extra scientific geriatrics training embedded in the emergency department. And all these people and protocols are there to help us identify and address the biopsychosocial needs that are unique and important to older adults. And in the same way that we were taught that kids are different and you need a different approach, it turns out that in very many cases, older adults are also different. You do different things, you think about them differently, you have a paradigm shift.
So you have all these policies and protocols, but really that's not how we know change occurs in emergency departments, right? And we know that this vulnerable age, like this group of people, the older adults, are really, really hard to handle and to work with in the emergency department. So how do you implement all these protocols and policies? It's not so simple, right? And so when we were thinking about how do you actually make meaningful change in departments, it's not by like shoving policies down people's throat, right? That doesn't work necessarily. Education is the way we do that. And so that is what we were coming to we're like, okay, how do we do this? How do we put this all together? Let's think about how we educate folks in the emergency department, from med students, residents, faculty, advanced practice providers, and nurses. It's really through education and how do we actually develop an educational system on how to care for older adults in emergency departments.
All right, so what we're hoping you're gonna walk away with today are these goals. There's really no one right way to do this. It's very system dependent. We're going to try and give you a set of tools, some of which you take, some of which you're going to leave, but go home with something that you can implement. And we really want to talk about what are going to be the top 5 most critical topics that you should address or cover based on our own expert opinion, our humble opinion, not so what you should cover. So we're going to talk about needs assessments, and Nida, you sort of started this process. Like, what needs assessments were out there when you started?
Oh my God, such a good question. So we started this like 5-6 years ago, pre-COVID. I have to say, well, not surprising, it was a little disheartening to see that there's actually a paucity of literature on geriatrics emergency medicine curriculum, and there was 0 on needs assessments for geriatric emergency medicine curriculum. So we kind of were at this like blank slate, and our team was like, okay, so we know that there are topics that we don't know anything about. The problem is we also don't know anything about those topics. So who can we turn to? What experts are there in the field of geriatric emergency medicine? How do we take what they know and put it into a curriculum or to needs assessment to decide what to do with the curriculum? So the first thing we did was we polled different like geriatric experts, and we found that there is an accrediting body for these geriatric emergency departments that puts out a policy and a guidebook on like, this is what you need to be like a really good geriatric emergency department. Yeah, there's all the policy stuff, but they actually have a section on the topics that providers need to have education on, and that list was about 15 things long. On there included things like atypical presentations of disease, differences in cardiology events or cardiac events in older adults, falls and trauma in older adults, end of life care, a list of 15. So basically what we did is we took those 15 things that the experts say that we all need to know about, and we turned them into a needs assessment tool with a Likert scale of 1 to 4. Not confident to confident on the knowledge, skills, and attitudes of different things. So let me give you an example. So needs assessments usually do KSA. So needs like a knowledge, skills, and assessment. So a knowledge question would be something like, I am able to identify all of the medications on my patient's list that are on the beers list. That's a good knowledge question. So like 1 to 4, do you do that? A skill would be like, I have a standardized approach to assessment of hearing and visual impairments in the emergency department. So the skill is like actually an assessment. And then like an attitude would be like, I feel confident in dealing with death and dying in the emergency department. So those are like the examples of what the different types of questions. And so the needs assessment tool that we put together, well, on those 15 different things, is about 30 questions long. And then we sent it out to everyone who works in our emergency department. So we sent it out to residents, attendings, advanced practice providers, medical students, and our nursing staff, just to kind of get a better sense of what everyone thinks. Surprisingly, I should say, or again, not surprisingly, is our population of providers was just like us. They don't really actually know very much about all the different things that they need to. And so that was what we found.
All right, so faced with the fact that everybody has limited comfort with every domain of geriatrics, so we decided to start just with talking about how to care for older adults. So in our intern boot camp, we talked about it. In our student didactics, we talked about it. The basic things like sitting at eye level, give some hearing support, some reading glasses, the basic concepts of get people up and walking when you can, feed and water them, make sure you're hydrated, they're kind of core concepts, pay attention to medications, things like that. We then took the larger subjects that were identified in the needs assessment and weaved them into our block curriculum. And when we talk about this, we have a block curriculum where we cover the curriculum over a 2-year period, so we set them into our blocks, covering the concept, the topics like renal, GI, gyne, dermatology, abdominal falls, kind of some core concepts. As we learn more about implementing our AGEM ED or geriatric ED, then we started thinking, oh, actually there are things like malnutrition, cognitive impairment, not totally sexy topics that probably are really important for us to cover. So that was sort of our first approach.
That's just like an enormous number of things, though. The next challenge would be, how do you organize those? How do you organize it into a curriculum? So what have people already thought about, or how do you generally do that in this?
Yeah, weaving these in the curriculum can be a challenge. I'm curious here, who has a block curriculum in your departments where it's like the cardiology block, the pulmonology block, the trauma block? That's like everybody. That's the vast majority of emergency medicine, graduate medical education, is this kind of like block curriculum. Now you can do a longitudinal curriculum within that block, which is what we did. That is hard to do unless you are like in charge of educating the department. And so like, I'm not one of the program directors, none of us are, but we were very fortunate at our institution to have buy-in from program leadership that thought this was really important. And so the AFEB, or the geriatrics curriculum, actually became this longitudinal 2-year rotating curriculum weaved into the blocks so that it would match, like, okay, so the cards block, we did atypical presentations of ACS in older adults. That was in that block. For the pulmonology block, we did specifically like a geriatrics pneumonia lecture. For trauma, we had a ground level fall lecture within that block curriculum. And so that is one way to do it, and we're, I think, very fortunate that we were able to actually just like seamlessly put in this 2-year, now we're on our, I think it's our second Now, I think we're on our third time. We've already done it for 4 years, so like now we're on our third iteration of the 2-year block cycle. So that's one way to do it. Another way to do it, let's say you don't have buy-in from education leadership, because it is really hard to get extra lectures into didactic, like residency lecture time. Like, I understand that, there's only so many hours and everybody has competing needs and they all want to be in that same like 4 hours to teach people. One way to do it is, okay, let's say you know that someone is giving a talk on UTIs. Collaborate with that person and say, you know what would be really cool if we could do like a birth to death UTI talk, because we know that pediatric UTIs are not like adult UTIs and are also not like geriatric UTIs. And so could you then just actually weave it into the content that's already starting and already being presented? And that's also like another way to get the same content into the curriculum without having to develop like something huge like a 2-year block curriculum, because I think that can be really daunting also. So those are your different options. But you know what was interesting to me, Eric, and maybe you might want to talk about a little bit, is there's this idea of block curriculums being like, we're going to talk about ACS or pneumonia today, rather than talking about things like chief complaint based, like shortness of breath or a chest pain lecture.
I thought that was on the next slide. So let's go talk about modalities. Although I suppose I could just address that now. So, yeah. So I think this is, you know, a concept that people have been arguing about. Medical educators have been arguing about this for generations, right? So you do the lecture-based, and it's probably the whole people like me who preferred that, or case-based. And I think, you know, case-based appeals to us as administrators, right? It's the way we think, it's the kind of patients we see. It's undifferentiated patients who come with a chief complaint, they don't come labeled with a diagnosis, and our job is to try and decipher that, you know, based on worst first, and the way we think as nurse physicians. The problem is that we were sort of forced into this, somewhat forced into this block format. You can have some case discussions and do it in different modalities. And let's talk about
so that's exactly right. So we do a lot of case-based learning. So even within a didactic lecture, so we did try really hard when developing the entire curriculum was to look at different learner types. Not everyone does well in this type of sitting environment, right? Like, obviously, actually, most young people probably aren't your like traditional learners sitting in like a lecture hall with a PowerPoint slide. We're like hands-on. We want to get in there. We're going to talk about cases, and so even our didactic lectures have a lot of case-based presentations within them, so that it's more natural. When we originally designed the curriculum was pre-COVID, so we also had a lot more actual hands-on tabletop stuff, simulations, and then COVID hit, and then obviously like all that went away and became all Zoom-based didactic lecture, which is probably like the worst type of lecture type to give. That being said, all of these types of contents can be done in any one of these types of formats, whether it's tabletop exercises, case-based learning within a didactic, straight didactics for 20 minutes, which I always recommend, like no more than 20 minutes. If nobody has an attention span that's more than 20 minutes. Like I'm like a 6-year-old brain. I feel like everyone has a 6-year-old brain. Like we have to move on to the next topic. But all of the geriatric, like the curriculum that we developed could be done in any one of those ways. So it's pretty flexible that way.
So we were faced with the fact that, I don't know if your place is like our place, but the faculty are frequently in the back row of the conference hall, either in email or charting, and not necessarily absorbing information as hopefully the residents are, or not able to participate in SIM like the residents are.
And like on Zoom, everyone's face is dark out, like there's nobody's faces on, so they're even less absorbing the Zoom lecture content.
So we felt like we needed to create a strategy to address the faculty who are going to be teaching and supervising and guiding people on shift. So we tried a couple different methods, or we are trying a couple different methods. One is through the case, the QI cases, or the case conference circulation. So either, wow, this is something that could have gone a little bit better, here are the tips and tricks we learned, or this was a case that worked out really well. You know, so we're celebrating that way. We did email some tips and tricks, just kind of fun facts, which does fall into the hopeful. I mean, emails out to you. I hope that you read it, and I hope that you absorb it. I have started having this like a segment called Geriatric Gems during our faculty meetings, so I've got 5 to 10 minutes to talk about a topic, whether it's our approach to delirium, or hey, we've got a physical therapist, here's what you can use them for, or palliative care, medications, etc. Having some of those people come in and give just a quickie 5-minute nugget to the faculty so that they can take real tips and use them on their shift. Are some of the things that we did to sort of address the faculty resident mismatch in their education strategy.
So basically, there's like no excuse for anyone not to know some of these rules, and we're giving it to them in so many different ways. It's almost like it is being shoved down everyone's throats. Like, take better care of our older adults.
All right, so there's a lot to cover, and some of you are going to want to take your time, dive into all the topics, explore, get your own topics to write up and teach. Some of you have no time. It's like, just please, I just need a few highlights to touch on. And it's kind of like a trip. Sometimes you have a month to spend in France, and sometimes you have 3 days to see France, and it's nice in those cases to have a guidebook with recommendations. So in the spirit of Lonely Planet, Rich Steve's, Fodor's, we're going to give you our top tips, top sites and topics to visit on your journey through the geriatric EV curriculum. And here they are. Nida, start us with tip number 1.
Okay, so tip number 1 is be careful who you invite to give your lectures. So, it sounds obvious, but I'm going to say when we started this, we were like, you know what? This is an awesome curriculum. We are going to get like the best of the best of all these subspecialties. We're going to get the renal specialist, who's like the best in the renal. We're going to get the president of this subspecialty society to talk about their expertise. So like, these are heavy hitter speakers in those specific domains. Guess what doesn't work for EM providers? Non-EM providers who give lectures, right? Because we actually absorb information differently. We want somebody to speak to us who actually like has been in the trenches with us, who actually understands like what are we coming across in the emergency department, and we're not talking about some like esoteric pathophysiology that we all purposely ignored and have forgotten since medical school, right? So like, don't invite the presidents of societies. Invite the colleagues, your EM colleagues who are amazing speakers. That's who engages the audience of EM providers the best, which is like a no-brainer now, but you know, we didn't know that at first. So I would say tip number 1 is like, get your best EM speakers and they can speak on any of these topics. It does not take a subspecialist to talk about these topics.
So in the travel book language, this would be travel with like-minded people. So tip number 1.
Tip 1. So that's my tip number 1.
All right, so I have a short time to visit the places. What are the 5 best ones that I need to visit so that people won't say, I can't believe you went to Paris and didn't see the Louvre or something like that?
Great, so I would put like Eiffel Tower, number 1. Not really, no, just kidding. Yeah, so I think the top 5 didactic lectures that residents and faculty all respond to the most are the ones that actually have like kind of the most jaw-dropping statistics. So for example, if you hear that like, oh, did you know that 1/3 of old people who fall from standing break something? Everyone is like, what? The ground level fall lecture is really good like that because it shocks everyone. Another one that's also really good like that is delirium. We spend a lot of time in med school and in residency learning about ACS and sepsis and how morbid those are, right? Like a lot of time. You know, delirium is just as deadly and morbid as sepsis. Again, when it makes someone's jaw drop, they pay attention. So I would say those 2 are like pretty important lectures, but also like get everyone's attention. And then agitation. We all deal with what we call agitation in the emergency department. We all know what that looks like, right? Pulling that lines, trying to escape or elope. And then like to the worst is like being combative or being physically assaulted. And, like, so lecture on how do you prevent that? Because everyone wants to stay safe. No one wants to get injured by this like frail old man who like takes her cane and hits you in the face. Like you want to avoid that. So how do you avoid that? So lectures specifically dedicated to agitation, to reduce that, and how do you reduce restraint? This would be like a 3rd one. For us, I will say we have really great pharmacists who give like really good pharmacy lectures, and so our residents really enjoy any pharma lecture given by our pharmacists. And so for us, anything that has to do with polypharmacy or BEERS list, which is the like do not give meds to older adults list, do very, 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 very well, and are actually very, very important because you can actually make very meaningful change for patients when they're being discharged. And then another one that has jaw-dropping information is UTIs. Because everyone, for some reason, from triage, or there's a UA on every older adult, for any reason whatsoever, and they shouldn't. And so when you tell people you're gonna change how they actually practice and impact their clinical practice by one lecture, that's another one I put on the top 5 list. So those would be my like top 5.
You left off goals of care conversations and life care.
Eric,
How did you do that?
it's like you're a plant, oh my gosh. Yes, you're totally right. Goals of care and end of life discussions are like, I would say actually, one of the #1 things to have in an emergency department. I use these top 5 as my didactic top 5. Goals of care conversations and those end of life conversations really lend themselves best to simulation. So I highly, highly recommend incorporating those into your sim. Thanks, Eric. I would not forget your most important topic.
You left off malnutrition.
Okay, so I like malnutrition. I think it's a very sexy topic. No one else seems to think it's great. I would probably plan those. So that's kind of what we thought were like the most important. So I think we have 1 minute left for like rapid fire, 2 minutes left for rapid fire questions before we close out and just for our final takeaways. There are 0 questions. You all are like, I'm gonna get 5 awesome lectures on this content tomorrow. Maybe not tomorrow. We get that from SAEM. Well, if anyone has any questions, I know that Eric, Jim, and I are always available on email. Our emails are our first name and our last name at ucsf.edu. And we hope that by the end of this, you did take away how to kind of build a needs assessment, how to actually integrate types of geriatric content into the curriculum that you already have. You don't have to make something crazy. Different types of learning modalities, and then how we all have done it to also improve practice of career balance. Thank you all so much for coming this afternoon.